diseases just to get the interest going. So please sit. So that's why I think at the end of the day, it's a learning point. So I think you can also clarify why you named things the way they were named. Some of it is obvious, but some of it we may need the, the connection between it. Some we get it, but some we don't. So, but I think Nishant was anyway presented here as post-moms. No, it's okay. Both ways goes. So this is a constant thing where the entire hospital looks forward to our notices to figure out what we might be presenting. So there's a challenge there also. So it's good to put it. It's fun to have a different approach to it. But the relationship should come out by the time you finish the presentation. Go ahead, Abhay.
Good morning, everyone. I'm Dr. Abhay. I'm presenting on behalf of Medicine 5. So my case was of a 31-year-old shopkeeper who presented to our OPD from Bihar. He was apparently well until December 2024 when he had a decrease in effort tolerance, which he said for a month. He was able to do his normal activities, felt slightly breathless on climbing stairs with an episode of small volume hemoptysis, which is going on for a month. But otherwise, no chest pain, no cough, no sputum production of fever, no loss of weight or appetite. There was a past history of a presumed pulmonary TB because of a similar episode, which is 10 years ago, for which he was treated with 6 months of ATT. Otherwise, he's a known smoker and an occasional ethanol consumer. In general physical examination, we found out that his BMI was normal, pulse rate was 96 beats per minute, regular of normal volume. The PP of 110 was 70 millimeters of mercury, and normal respiratory rate with a normal JVP and normal general physical examination findings. His otherwise respiratory system examination was unremarkable. His CNS and abdomen examination also was found to be normal. On cardiovascular examination, we found out that on inspection, he had a normal chest wall shape and symmetry. So there's no precordial bulge which was seen, no visible pulsation, no scars, sinuses, or dilated veins. However, on palpation, there was a hyperdynamic apex which was felt at the 7th intercostal space, 2 centimeter lateral to the mid-clavicular line, with a grade 2 parasternal heave and a left sternal border thrill which was present. On percussion, there was a dull left second intercostal space note which was appreciated. And on auscultation, we felt that the S1 was heard normally with a loud P2, with a loud pansystolic murmur heard at the left sternal border. So at this point, the summary was of a 31-year-old man from Bihar who came with reduced effort tolerance of NYHA grade 2 with 1 episode of hemoptysis. And on examination, he had an hyperdynamic apex in the left 7th intercostal space, lateral to the mid-clavicular line, with a parasternal heave, a loud P2, and a grade 4 pansystolic murmur felt in the left sternal border. So would anyone want to guess, any guesses on the probable differentials at this point?
Thanks for stopping there, Abhay. Anybody from the, I'm not going to call you audience, anybody from our group of interested people? Yeah. Some very relevant, the way Abhay is presented. Is there any thoughts on what could be happening? There was no fever, right?
No fever.
Anybody, second years? Abhay is waiting. Give it a try. It's not a punishment for you all. We are not going to mark you down. Just give it a try. Yeah, please. Yeah, so that's there on the clinical findings. So he's got this hyperdynamic apex, he's got shifted out, he's got loud features of pulmonary hypertension. Thanks, Hamza. Please go ahead.
So at this point, we were considering a probable cardiovascular etiology, and our differentials which we considered was a ventricular septal defect with pulmonary hypertension, followed by a patent ductus arteriosus with a pulmonary hypertension, or a dilated cardiomyopathy with probable pulmonary hypertension and a tricuspid regurgitation. So he had a left sternal border pansystolic murmur, which. So this was a patient's echocardiogram, which was on the left side, and you can see that. I'm not able to get the point. So basically, this is a pulmonary trunk on the top.
You have a mouse here? Is it
not able to actually?
It's not able. Sure. Please go ahead and show. It doesn't matter.
This is a pulmonary trunk. You can see the PDA here of the descending aorta. That's the same cut section, which is seen in the article. So basically, you can see the markings which shows the PDA, the descending abdominal aorta, and main pulmonary trunk with the connection there, which is the PDA. So the echocardiogram findings of a patient revealed a 9.8 mm PDA, patent ductus arteriosus, with a predominantly left to right shunt, with pulmonary artery hypertension, a mild TR, mild MR, and ejection fraction of 57%. So brief anatomy, as you all know, ductus arteriosus is a fetal vessel which allows oxygenated blood from the placenta to bypass the lungs in utero and enter in the descending aorta. It's a remnant of the distal 6 aortic arch, connects the proximal descending aorta to the main pulmonary artery, functionally closes by around 24 hours, but a complete anatomical closure happens by 3 weeks. Typical presentations are often of a patient who comes with continuous machinery murmur, which is described below the left upper sternal border, radiating to the back with wide pulse pressure, prominent precordial impulse, and a bounding peripheral pulse. However, the murmur may become shortened, as in this case, to a systolic murmur or even an ejection systolic murmur after the onset of pulmonary hypertension. PDA in adults is not something which is very often seen. In full-term infants, they had found that there's 1 in 2,000 incidence of PDA, and it makes up around 5 to 10% of all the congenital heart diseases. But it is encountered very rarely in adulthood and often manifests when the adults develop systemic hypertension or when there is isomengerization when resulting from severe pulmonary artery hypertension. Usually the PDA closure, we prefer a transcatheter closure. Indications are a pulmonary artery hypertension or a left ventricular volume overload, with contraindications being severe PAH with isomengerization. If it is incidentally detected, often does not require closure. And a study showed that bacterial endocarditis is often a rare complication of PDA. So one of the prognosis factor is reversible pulmonary hypertension. So I had gone through a case series which showed that there's 137 adults or adolescent patients with PDA and pulmonary artery hypertension, of whom 98% of patients tolerated a trial of occlusion and underwent permanent device closure. In these, 13% of these patients had residual pulmonary hypertension, but only 5 required medical management for the PAH. So in our patient, he underwent a cardiac catheterization under cardiology, which showed a large PDA with predominant left to right shunt, with moderate pulmonary hypertension and a reversible pulmonary artery hypertension. He underwent a transfemoral PDA closure. Post-procedure, the hospital stay was uneventful and patient is discharged. So the take-home messages would be primarily two. The clinical presentation of PDA in adult. They can present with a continuous murmur, which is often classical, but it can also be presented as a systolic murmur, a pan-systolic murmur, or an ejection systolic murmur in the presence of an underlying pulmonary artery hypertension. In the absence of isomengerization, this pulmonary hypertension due to PDA is usually reversible with device closure. Thank you.
Thank you, Abhay. Can I ask, if you didn't have the echo or any of those findings, what would your differentials have been?
It would have been primarily a cardiac localization because of the symptoms of.
Yeah, what would you have said? Like, we looked at some, you gave us some differentials.
Probably VSD would be the first differential because of a left sternal border pansystolic murmur.
Yeah, classical PDA associations are more of, of course, a missionary murmur, as you mentioned, but with pulmonary hypertension, you can get it shortened and localized elsewhere. Yes. Because your main thing was the localization was in the left sternal border. So that could give rise to many other. How old was he?
He's 31.
31. Okay. And not diagnosed prior to
no
this
diagnosis.
To have any...
He just had a prior history of being diagnosed as TB for the hemoptysis.
TB for the hemoptysis.
But otherwise not validated.
Any other questions or discussion from the team or from the audience? Yes, please.
His pulmonary hypertension was mild, you said.
Moderate.
Hemoptysis, I'm just wondering whether, you either expect the pressures to be high or something.
Yeah. So the case studies the case studies also showed that only when you have a very severe pH, they often end up having hemoptysis. Yeah, just a little weird.
He did not have hemoptysis. But that was TB. No,
we don't. We don't know. We just have the symptom and the treatment given, but I don't think we have X-ray or something from that time.
X-ray we had done in our.
No, I meant
no.
That old
agree on it. That was TB because there is no isomer syndrome. They didn't have so he did not have severe pH to explain that.
Yeah. I mean, we're just looking at the correlation of what you finally find and what you initially thought when you examined the patient. We agree that the left sternal border localization is why we went with certain differentials as compared to a valvular, like a MR. But after that, it then becomes a bit thing. We are fortunate to have investigations that help us, but and to reverse his problem in that way. Any other comments? Yes, please, Bennett, please go ahead.
Is it clear that the potential is there in the first
Yes, sir.
That is not also explained because it makes clinically it makes sense to
Left
say
hand.
PhD as a private users, even though we are very sure that there is no use.
Can I clarify? I actually saw this patient in opinion. So my first diagnosis was a PhD. Hence I really described it as lower, the left standard border. I actually thought it was lower standard border with the maximum.
Sure.
Impulse was there. So PDA is actually in the upper circle. So we left it a little ambiguous in the left circle for this case. I didn't think it was a PhD. He had some hemophilisis 1 month ago, which in 2-3 days resolved, and then he did not recur at all. And at that time, he had received some short course of antibiotics. Whether that is what resolved or not, unclear, but it was not an ongoing problem basically. And then his respiratory system examination was normal. And even the previous TB, I mean, my impression of it was that we don't even know if this TB might have been some similar approach. I just the confusion. But overall volume overload causing features of left ventricular volume overload is definitely something. As well.
Thank you, Amita, for that. Abhay, thank you. In the interest of time, I'll have to stop here, but I'm glad we had some discussion on it. And I think clinical localization is what we appreciate first and then the diagnosis. Thank you so much. Urvashi, can you please?